Assalamu alaikum everyone. Next topic of discussion is PNH, paroxysmal nocturnal hemoglobinuria. Definition states an acquired genetic defect of the hematopoietic stem cell characterized by a triad of hemolytic anemia, pancytopenia, and thrombosis. You can remember it by PTH, PNH. So remove N, put T instead of N, so it becomes PTH. P pancytopenia, T thrombosis, and H hemolytic anemia. Epidemiology is median age of onset approximately 35 to 40 years. Pathophysiology. So physiologically, a membrane-bound glycosphatidyl inositol anchor (GPI anchor) protects RBC against complement-mediated hemolysis. Acquired mutation in the PIGA gene, phosphatidyl inositol glycan gene anchor, located on the X chromosome. So GPI anchor loses its protective effect, RBC destruction by complement and reticular endothelial system. Intravascular and extravascular hemolysis occur. The GPI anchor protein involved in PNH are GD55, also known as DEF, decay accelerating factor, and CD59, which is also known as MERL, membrane inhibitor of reactive lysis. PNH can also occur in patients with aplastic anemia and MDS. Clinical features: so pallor, excessive fatigue, weakness, intermittent jaundice, episodes of hemoglobinuria causing pink, red, or dark urine, which usually occur in the morning due to concentration of urine overnight. Vasoconstriction occur due to the scavenging of nitric oxides by the free HB. So nitric oxide level decrease, due to which vasoconstriction occur. Symptoms are headache, pulmonary hypertension, abdominal pain, dysphagia, and erectile dysfunction. Venous thrombosis in unusual location, for example hepatic, cerebral, and or abdominal vein, increase risk of infection in case of pancytopenia. Diagnostics: so in CVC you will have anemia, thrombocytopenia, and or pancytopenia. Bone marrow failure occur in almost all patients to some degree, usually increased retic count due to hemolysis. Hemolysis workup: so there decreased hepatoglobin, hemocitrinuria, hemoglobinuria. Home test will be negative because hemolysis occur by complement, alternative pathway of the complement, not by antibodies. Flow cytometry, it's the confirmatory test for PNH. So can show the deficiency of GPI link protein on the surface of RBC and WBC, CD55 and CD59. So there's a confirmatory test, flow cytometry. You can also remember it by CATCH PNH. C cytopenias, A aplastic anemia or MDS, T thrombosis, and C Coombs negative hemolysis, H hemoglobinuria. Typical biochemical findings in hemolysis include decreased hepatoglobin, increased LDH, increased indirect bilirubin concentration, peripheral smear abnormality, increased retic count, schistocytes, spherocytes, polychromasia, and urinalysis abnormality, hemoglobinuria, hemocitrinuria, and urobilinogen. Treatment options: so patient with mild or no clinical manifestation, watchful waiting. Patient with significant clinical manifestation, start targeted therapy and provide supportive care for all patients. Targeted therapy: first line treatment, complement inhibition with anti-C5 antibody, eculizumab, revolizumab. Indications are severe anemia, thrombosis, severe fatigue, pain, crisis, and in-organ damage. Supportive care: in case of anemia, consider RBC transfusion. In symptomatic or severe anemia, HP less than 7, consider iron and folic acid supplementation as well. Thrombosis: avoid medication that increase the risk of thrombosis, for example OCPs. Start therapeutic anticoagulation without delay for any venous thromboembolic event, example DVT, pulmonary embolism, Neisseria meningitis infection, high risk of infection in patients receiving eculizumab. Consider vaccination and antibiotic prophylaxis. Complications: so vasoconstriction and thrombotic emboli leading to thrombotic complication, for example infarction, Budd-Chiari syndrome, and development of acute leukemia. So that's all about PNH.